The hip essentially is a ball and socket joint. On the side of the pelvis is a cartilage-lined socket that sits facing outwards, and then at the top of the femur, the thigh bone, there is a ball, again coated with cartilage. And the most common reason to have a total hip replacement is because that joint becomes arthritic, by which essentially we mean that the layer of cartilage on both sides of the joint wears away. So what an orthopaedic surgeon then can do is to open up the hip, can remove the damaged cartilage lining from the inside of the socket, similarly can remove the ball bit at the top of the thigh bone, and both of those are replaced with a new artificial articulation that can be made out of a variety of different materials depending on individual patient requirements. But because the two sides of the joint, the damaged sides of the joint, have both been replaced, the logic is that the source of the pain is removed and the patient can then return to a full level of pain-free function. When you get to the stage where your hip arthritis is beginning to have an adverse effect on you being able to do the things on a day-to-day basis that you need to do, then that's the time for us to have a discussion about whether hip replacement is right for you. And probably the commonest things that we hear from patients are that their walking distance is starting to be limited by their pain, that they're increasingly finding that they need painkillers on a day-to-day basis, whereas previously they were not needing such regular analgesia, and also increasingly patients start to feel that they're being woken up on a nightly basis by their pain, so that even at rest their arthritis really is causing them quite a significant amount of discomfort. Well, really, the aim of a hip replacement is to get back to the level of pain-free function that you had before the arthritic process started, and really to allow you to go back to doing the things that you most love in life. And one of the really exciting things that we often look to try and achieve is to get back to what we call the silent hip, which we mean really that on a day-to-day basis, once your hip has been replaced and you've gone through the recovery process, that you don't even remember on a day-to-day basis that you've had the surgery in the first place. And it's very exciting for us when we see people 6 or 12 months down the line and they come back and they show us photographs of them swimming in the sea or riding a bike or going on a skiing holiday, and that really does show us that their hip is working exactly as it would if they had never had the pain and the arthritis in the first place. Normally, a patient would be admitted on the day of surgery, and having been checked in, you would be taken around to the anaesthetic room where you'd be given an anaesthetic. Now, increasingly, we've got to move towards using a spinal anaesthetic rather than a general anaesthetic. So general anaesthetic is where you're formally put to sleep. Often for joint replacement surgery now, we favour a spinal anaesthetic where an injection is given into your spine which will numb you from the waist down. Normally with the patient lying on their side, the surgeon will then gain access to the hip joint by dissecting through the skin, passing between the different muscle layers around the hip joint, and then using special surgical instruments to remove the damaged ball and socket joints. After inserting a series of different trial implants to make sure that the correct size of prosthesis is selected, we would then put in an artificial articulation to restore the normal function and anatomy of the hip as it was before the arthritic process started. The wound is then normally sewn up in layers with dissolvable stitches, and usually we would hope to have patients already up and walking around the ward within a few hours of their surgery. Most patients do find, however, for a couple of weeks at least, that there is quite a bit of discomfort. Something that often is very psychologically empowering, however, is that they feel even early on, when they're experiencing quite a bit of pain from the surgery itself, that the deep-rooted arthritic pain that they experienced in the months and years leading up to the decision to have the surgery often is resolved instantaneously, and patients then can feel on a day-to-day basis that the surgical pain improves and improves and improves, and they can see a time when in the future they know they're going to be completely pain-free. Recovery is actually surprisingly fast. We would normally expect to have patients up and walking around the ward on the same day as their operation, and normally would be discharged within 48 to 72 hours of surgery. The majority of patients are able to mobilise independently without crutches within 10 to 14 days of surgery, and outpatient physiotherapy and ongoing engagement with the rehabilitation process is absolutely crucial. And some patients are surprised to find that within 3 to 4 weeks of their operation, they're actually able to go out and walk a mile or two a day. Certainly the majority of patients, by the time they come back for their 6-week follow-up, are starting to reach really quite a good level of independent mobility. Hip replacement, like all surgery, does of course carry with it a small degree of risk. There are risks that are generic risks inherent in all surgery, for example, the risk of infection, the risk of bleeding, the risk of blood clot formation, and the risk of injury to nerves or blood vessels. These are all very low risks, and the likelihood of any of these occurring after a standard hip replacement would be expected to be less than 1%. There are then also risks that are specific to hip replacement surgery. In particular, there is a risk of fracture or a crack to the bone. Normally, were this to occur, the surgeon would repair the fracture at the same time, and this wouldn't be expected to have an adverse effect on the longer-term outcome of the operation. There is a risk of dislocation, by which we mean that the ball and the sockets can become separated from one another following the surgery. And the final thing also specific to hip replacement surgery is that there is a small risk that the patient can be aware of a slight discrepancy in the leg length after the hip replacement. This is often actually due to the fact that the arthritic process itself causes shortening of the hip. As the cartilage wears away, the leg becomes shorter, and the surgeon invariably will try to restore the anatomy back to the correct position at the time of surgery. Some patients report afterwards for a few weeks that they can feel that things feel a little bit tight because the ligaments have been stretched back out to the correct length, and most patients find that within 5 to 6 weeks this stops being something they were aware of.